All right, welcome back to episode 4 of Vital Conversations. My name is Dr. Mike Shadow, and got a guest on today, Dr. Jim Zaleski. Jim, tell us a little bit about yourself.
I've been working in PT for 6 years now. Graduated from Rutgers University in 2019. Started working in outpatient orthopedic, the big box PT stores. We all know the names, don't want to single anybody out. Worked in that model for a while. Got to see how progression in the field went from low volume to high volume, seeing a lot of patients per day, up to 15 to 20. Worked with Mike here at our previous employer together, and saw the writing on the wall that that was not the best way to do things and get the best outcomes for our patients. So in 2023, started my own cash pay practice in Philadelphia. I work out of Open Box Athletics, one of the biggest CrossFit gyms in the city. So I get to treat a ton of CrossFitters, powerlifters, runners, cyclists, triathletes, yogis, pretty much anyone that likes to train hard, likes to stay active, which has been a lot of fun working with that clientele. People are very motivated to get better. And I feel like that gives me, working with this population, lifters, has given me a pretty interesting outlook and experience in a very niche part of physical therapy in a very underserved population. And it's been a lot of fun, been rock and roll.
Cool. So today's topic, we're going to be talking about neck pain.
I see it a lot.
So we'll go into maybe some common myths, or maybe how common neck pain is, some of the potential causes, some common myths regarding neck pain, how an assessment might look at either Vital PT or Path to Performance, and maybe what the phases of rehab would be to get someone out of neck pain. So let's start with this, Jim. So tell me, how common is neck pain?
In my practice, it is extremely common in lifters, especially Olympic lifters with all the kind of overhead work that they're doing. In CrossFit, you're doing a lot of gymnastics, you're doing handstand push-ups. People are banging their heads straight into the ground. All the kipping pull-ups, some of the cues that are given for Olympic lifting is throwing your head through the window with catching snatches, clean and jerks, things like that, which tends to put a ton of stress on that neck, kind of upper thoracic spine, that cervico-thoracic junction. We see a ton of issues through there. Honestly, it's probably the most common thing I treat at this point is neck, and honestly, and low backs too, which we'll put in a different episode. The other thing, not only with lifters and athletes, is over the past 5 years with the COVID pandemic and work from home, everybody's sitting at their desk all day doing Zoom calls and whatnot, and I feel like it's just, I would say it's probably 50% of my caseloads, honestly. Neck or thoracic pain, that classic, oh, I strained my rhomboid, been mashing that out for 6 months and needling it, and it gets better for a day, comes back. That has been so common lately, honestly. And we'll talk more about that and how that kind of works. Referral patterns. It's here, it's my rhomboid. I see that all the time. So very common in my practice.
I would say, I think in general, more worldwide, so low back pain is definitely the number one most common thing. And I think neck pain is either close second or third or something like that.
For sure.
Neck pain.
Neck, shoulder, and it's kind of that blended combination of the two that I see a lot.
So let's go into some potential causes, or maybe a lack of research or inability to find a cause and effect relationship. So, and this might even blend in with the potential myths as well. Can you think of any, based on the research, things that cause neck pain? I'll start with this. So there tends to be a lack of research that can find a true cause and effect relationship of this always causes neck pain kind of thing. Can you think of anything that is actually supported by research, at least? That
it's tough because it's so variable and everybody's lives are different. Your postures, your daily activities, routines, training, programming, etc. I feel like in the research, I don't know if I've seen anything that pinpoints it, but what tends to be a common finding in the research I've looked at with neck pain is it's prolonged positions. So, for example, the one that popped in my head right away was they've done studies on basically mechanics. So if you think of, you go to Jiffy Lube or something, you get your oil change, there's guys that, right, they have a car on the lift, they're looking up like this all day long, working on cars like this. And that can actually cause neck pain, and actually there's a higher incidence of folks that are constantly in extension looking up, like electricians and things, having like vertebral artery issues and stuff from just being in that extended position all the time. And neck pain with headaches is super common in those folks as well. And also vertigo is another one. I've had some folks coming in mechanics and for people working on their boats in the summer, and they look up and they get vertigo. And so I think it's tough. There's not a lot out there as far as a pinpoint reason, but that's one of the things is anytime you spend too much time in one posture or position can definitely cause some issues in the neck and the upper back. And the classic one, I mentioned mechanics looking up, but everybody knows we've all been here doing the desk thing. You're sitting looking at your phone like this for hours, and then you're on your computer like this for hours, so then things get tight, get stiff, and it's just being in those sustained positions, I think, is the biggest correlation I've seen, other than the obvious CrossFitter who's doing high rep handstand push-ups and just cranking their head on the floor and compressing the spine. But
I would say it's more so spending too much time in one position and just a lack of just general movement throughout the day.
yes, especially in this country.
Especially in the US where people's jobs tend to be very high stress, need to try and accomplish a lot and just go all the time. When are those people ever going to fit movement in throughout the day, right? Let's go into some myths. So right off the bat, a good segue is a lot of people claim that, oh, it's your posture that's causing the neck pain and you just have to correct your posture and that'll fix all your problems. There is a little bit of validity to that. If you're already in pain, being in more often than not, being in this forward head or flexed kind of neck posture, it'll tend to aggravate your symptoms. Whether or not it's the cause of the symptoms, I doubt it. It might contribute. Well, let me try that again. It might contribute to an aggravation of your symptoms, but it's not as likely to be the cause. So that's one myth, is that poor posture causes neck pain. Likely not. If it aggravates it, often adopting a posture away from that aggravating posture can be very helpful with calming symptoms down for the time being, but it's not going to be the be-all solution to your issues.
Right, absolutely. And that's the main point. It's not the end-all for anyone's issues usually, but if there's a symptom change component to having a better posture and makes you feel better, eases the pain, then it's definitely worthwhile to get out of those painful postures and things. But
do you have a patient example of it's a clear-cut, oh, we need to work on this person, or this person needs to avoid a flexed or kyphotic or rounded posture in the assessment?
A lot. It's actually quite a few come to mind. Again, with all the work from home that's been going on over the past couple of years, but I have someone who just popped in mind is a video game developer. So they spend a lot of time of their day playing video games, being on their computer.
That's an awesome job.
Pretty cool job. I'm definitely jealous. And it's cool talking to the day-to-day and stuff, but about how his day is. But definitely posture is a huge part of that, because it was literally one of parts of my assessment, really, to test this out with postures. I have someone sit on my treatment table with no back support, and while I'm doing their subjective exam, I'm looking at their posture. And basically, he sat down and he was in a good posture position. We're talking, I could tell he's not in much pain, whatever. And as the eval progressed and he was sitting there for about 20 minutes or so, I started to see the true posture come out where he was starting to get tired. And then I was like, asking him, hey, how you feeling after I've been sitting here for 20 minutes? And I was like, oh man, my shoulder blade's hurting. And I'm like, all right, let's do a posture correction, have him sit up straight. And within 20 or 30 seconds, oh, it actually feels better.
So that is an example of addressing posture to help manage the symptoms is definitely indicated for that person, right?
Yep.
Versus if you try and change someone's posture and either it gets worse or just nothing happens,
no effect,
then maybe we don't have to focus on addressing the posture, at least for now.
Yeah, it's not the number one priority at this point, although they would probably benefit from a posture correction down the road just for general functioning. And there is a little bit, the thing about posture that I think does matter. We are human beings. We're imperfect. A lot of us, social media is big nowadays. We're on camera today. Some people I've noticed, clients of mine, are actually like, hey, I want to work on my posture, not to help my pain, but just to look better. I don't want people to look at me and think I'm like a fit athlete. I'm not. No one wants a nerd neck.
Yeah.
No one wants to be that guy that's going through life like this and then you can't get out of that posture. So there is a little bit of a vanity component to it, I think is the word I was looking for here. Which, hey, we all want to look good. We work out to feel good and look good. It goes hand in hand. Posture's
mental
a big
health
part of it.
component of that, right?
Huge. Exactly.
So another common myth is, and we will have people come in being diagnosed with this a lot. Either they're in so much pain that they had to go to the hospital and they were given this diagnosis, or even by their primary care physician of, oh, it's a muscle
strain. You strained it. Muscle relaxers, they're prescribed that stuff to help it. So when people have neck pain or shoulder pain pop up, or interscapular pain, it can be as simple as something as I slept on it funny, or I was, the common one I get is I traveled on an airplane, slept in the hotel bed that was uncomfortable for the weekend. The mechanism a lot of times for a muscle strain, when you ask people that, oh, I strained my neck, you ask them, well, how'd you strain your neck? Oh, I slept on it funny. You're not recruiting muscle in an overloaded fashion that's going to put so much stress on that muscle in your trap that you're going to tear your trap or strain your trap. That is a big, strong muscle. Sleeping in a hotel bed for 3 days that's uncomfortable, or going on an airplane, is not straining the muscle. Usually it's coming from the joint. The root of the problem is usually at the joint level, and it's not actually a muscle strain, but the way your neck can refer pain to the shoulder, it presents itself, the somatic pain referral, we call it, can present as muscle pain. But usually the root of it is at the spine.
Yeah.
And that's where you'll have people get on muscle relaxers and things, and they're like, I don't feel any different. And it's like, the problem wasn't the muscle. On the other side of that, you'll see someone who'll get like a steroid, where they'll take an oral steroid and they'll feel a lot better. And that's usually because the pain is coming from nerve, disc, or facet, whatever the pain generating
like a little bit of
structure
inflammation.
could be, the inflammation there. So it helps with inflammation. They get better. Muscle relaxers a lot of times don't help that stuff because it's deeper.
And on top of that, if you hop on steroids, even if you're not in pain,
you're gonna feel like
take it, you're
great.
gonna feel like $1 million.
Day 3, you're like, woo! I'm Superman, Superwoman.
All right. Now, why might someone that doesn't actually have a muscle strain feel better from taking a muscle relaxer? Do you have an idea of why that might be?
They can, and again, it's not that the muscle relaxers don't always work, but it's common I see that they don't work for folks that are diagnosed with a strain. And it's because it may work sometimes, because when you have this issue at the joint level, so at the spine, your body's defense mechanism is basically to guard that area. So anytime you have pain in an area, your brain tells your body, oh, we got something going on here. We got a pain response. Your brain's receiving these pain signals. We need to do something about this. And it just basically tells those muscles to lock up
We need to lock
and guard that
down.
area. We're going to lock this shit down. We're not letting anything else get hurt here. The downside is then you feel worse because you have all this crazy muscle tension. You're guarded. Then you end up in these hunched postures. It becomes a little bit of a snowball effect, if you will. But so sometimes if people are really guarded heavily and they're in a lot of pain, muscle relaxers will help, but they usually aren't fixing the root of the problem, was my point with those.
Yes. Let's see. What's another one? Oh, the one potential cause of neck pain, a myth, is, oh, your spine's out of alignment.
The good old out of alignment. This is a fun one.
Now, if your spine was out of alignment, you probably would not be able to even walk into our treatment office. If there was an actual vertebrae that was slipped in one direction or another, if that were to actually happen, you would have spinal cord compression and probably not
It would
be
be
able to
catastrophically bad for you.
You would know, and you wouldn't even be watching this video. You'd be in the hospital.
You'd be in the emergency room
on a respirator or something like that. Or
Now, here's the thing, though. I will say, caveat here to that, though. There is a condition that occurs pretty commonly in the low back, the lumbar spine, that I've treated quite a bit. Actually, Dr. Shadow here has helped me when I've had this issue. So there's what's called an acute lateral shift deformity, which can happen at the low back, where you can actually, whether it be the disc or the facet.
You've had it on your neck, too.
I've had it on my neck, too. So actually, there's a wry neck deformity, too, where you can be shifted at your neck, or you're stuck to the side like this, and at your back, you're shifted to the side. And there you technically are out of alignment, but it's not that your vertebrae are shifted off center so much that you're literally out of alignment. It is crooked. It's like a temporary scoliosis, but can be fixed with the right treatment.
And usually the
but
cause
that's the true
for that,
out of alignment. It does happen.
And usually the cause of that is that there's so much pressure on one nerve or the other, one side or the other, that your body's natural response is to just try and offload that area,
Get away from it,
to help reduce that compression. And usually that actually ends up working against you and actually making things worse. So usually the fix for that, if there's a lateral shift, is to just shift you the other way over and over and over again.
Thousands of reps. Can take thousands of reps.
And those are the most
pretty tough,
grueling, intensive, takes a long time to get out of that sometimes. Sometimes it's like you do 10 and the person feels amazing.
You hit a home run. Awesome.
For you, we've been in the clinic together where literally between patients or while a patient's doing an exercise, you're just at the wall just cranking out side glides.
You go around the corner and there's Jim in the back, the eval room by himself, just doing hundreds of side glides. And that was pretty interesting.
And you just looked
not
miserable
great.
On your face, too.
Just in so much pain. I'll say, playing sports, being an athlete, we all deal with aches and pains, injuries. It's just a part of life. It really is. But that one in particular, I think, played the worst mental game with me, because waking up every day, having my leg going numb, and then I was in a high volume treatment model at the time. We were working together, just grinding out 15 to whatever, 20 people a day, basically patients rather, that we're trying to take care of. And you have your older folks that are having a little hip pain, like, oh, I'm in so much pain, 10 out of 10. And they're like, want me to rub their butt, do the piriformis release and all this stuff. And I'm just looking around the room and I'm like, I'm in more pain than anyone else in this room right now. And I'm literally shifted. My foot's going numb. And I'm like, oh, can you work on my glutes a little longer? And I'm like, Jesus Christ. But anyway, I digress. But so there are some malalignment issues that actually truly do occur, but it is way overly diagnosed. I don't know if I want to call out the practitioners that do this, but you hear this a lot in certain professions, the musculoskeletal realm, that, oh, you're out of alignment. Your leg length is totally out of whack, and your spine is crooked. And
if we do this one manipulation, it'll cure everything.
We'll do this one thing, crack you, and you'll be straightened out, and you'll be good to go. But you have to come back every week for the rest of your life to keep it good.
And that's where, again, we're not going to call out the kind of profession or anything, but just like any other profession, there's good and bad, right? So with that specific profession, yes, doing those techniques can help, but if that's all they do and they don't give you homework to work on, exercises that are tailored specifically to your needs, you need to get out of there and find someone that's more suited to help you achieve the goals that you're looking for.
I think that
It's the over reliance on a passive treatment. That's where
there you
the
go. You
issue
nailed it.
is.
Exactly.
Is that what you're about to say?
I was going to say that, and just the lack of, so us as being orthopedic physical therapists that work with athletes, we both do all the manual therapy techniques, manipulations, mobilizations, etc. I believe in them. They work every day. I use them on my athletes. They need it. But I think where some of the chiros of the world miss the boat is the progression from the passive treatment to now we got to load movement patterns. We need to get you back to training and progress things, address mobility impairments. We got muscle imbalances, poor technique. So if you're just going and getting cracked all the time and just expecting that's going to fix you, you're going to feel good for 24 to 48 hours, and then the pain's going to come right back. And then as soon as you go back to training with those poor movement patterns, or you have no hip internal rotation and you're just blowing your back out every time you squat, just crushing loaded flexion of your spine, and it's irritating things, it's not going to fix it.
Another way to think of that is like, so if you're an athlete and you're dealing with pain, so you have an active problem, right? So an active problem requires an active solution. So
well said. I like that. I'm going to steal that. That's
right?
great.
So if you're going in for these passive treatments of just getting soft tissue work, getting snap, crackle, pops, whatever, and leaving, that's addressing the symptoms, but not the root cause of whatever issue there was with your specific movement patterns or mechanics or whatever. That's why, yes, we can start with those passive things, but the goal is to get you off the table and into the gym as quickly, as efficiently, and as safely as possible. And that's where a lot of people can miss the boat. You ever hear of the parking lot effect? So you'll go in, get the snap, crackle, pops, whatever. You feel amazing, sigh of relief. You walk out into the parking lot, get into your car, and you're like, shit, my pain's immediately come back. That's the parking lot effect. That's like, yes, you got some temporary relief, but you didn't do anything afterwards to help drill home that improvement or that gain in your range of motion. Age. This one's not even specifically just reserved for the neck. Any ache or pain, people will immediately be like, I'm just getting older. Do you want to?
I have a 40-year-old client. This was actually yesterday. I did an eval. Rower, basically triathlete. Does a lot of rowing, swimming. He's doing Olympic lifting. Really strong, fit guy. And he comes in my office, and within the first, I don't know, probably 5 minutes of us talking together, he just throws the, well, some of the stuff, I think I'm just getting old. I'm 40 now, and just think this is just what happens. And my body's broken from all the years of training. And I think it's just been wear and tear. And this is going to be something I'm going to deal with the rest of my life. I think he even said, I'm going to mention at one point, and this is a whole other segue, topic we can go into, but my doctor, I had an x-ray and said I have the spine of a 99-year-old dead person, or whatever the hell they tell their people to freak them the hell out or whatever. So that is something that we need to do a good job of as providers, of breaking that thought process, because that can snowball quickly into where you get a pain science realm where people start to catastrophize and think negatively about their function and their body, and it can really set off a chain of events that can put you in a bad place if you're trying to recover from an injury. But man, it's everywhere, and I think the medical profession, I don't want to call them out, but I'm going to call them out. I think we need to do a better job of using words that aren't harmful to our patients when we tell them that they got something going on, because the age thing is tough. And I've had experience previously, even with a different case with an 18-year-old, or actually she was 17 in high school, wanted to be a Division I swimmer, was getting college looks, like doing great with her sport, had a low back injury, which happens. And she went to an orthopedic. They did a MRI, X-ray, and told her she had the back of a 90-year-old.
She's 17?
17 years old. She into the office and comes in for a PT. Just, I could tell it looked like she had the worst day of her life. Just looked like tears were about to just start coming out. And I was like, "What's up? What's going on?" "Oh, I went to Doc so and so, got the image back. He read me the results that I have the back of a 90-year-old. I'm not going to be able to swim. I'm not going to be able to do my Division I sport that this has been my dream of my whole life." Literally, her world crumbled because a doctor told her that she had the back of a 90-year-old, and went through the whole Adrian Lowe pain science. Just let her talk it out. The whole thing. What's your pain? At the beginning of the session was 7, 8 out of 10. She's crying. Literally spent the whole session, just talked to her, gave her encouragement. You're only 17. These images, you could look at anyone's spine, doing all the talking points of, okay, what we see in the image isn't really
not
representative
of how you can actually move,
or your prognosis or what you're experiencing. Yeah. Really, it's not great information, to be honest. Mm-hmm. And at the end of the session, literally just talking to her. I didn't even work on her or nothing. We just talked, gave her encouragement, maybe just worked on her, did a little soft tissue work, and she said her pain was like 2 when she left. And that right there tells you the mindset effect and how your mental process and how you think about yourself and your problem can really affect your symptoms. And I think that's just a good little example of a 40-year-old who's like, hey, I'm getting old. We all have this thing in our society. Once you hit 40, apparently, you might as well just check out and hang it up because you're going to die soon or whatever.
Go and then the
converse side of that is a 17-year-old who literally just went to a doc who said, on your x-ray, your back is whatever, a 90-year-old and freaked her the hell out. And
Yeah.
she almost gave
Might
up on
just
everything.
give up.
So it's something we got to battle on multiple fronts with the age
Yeah.
thing.
And when was that Evo? That was recently?
I had the one yesterday was the 40-year-old,
Oh.
the swimmer. That was a couple years back.
How's she doing now?
3 years ago. She had full recovery, went Division One, swim.
D1? Dude.
Probably working on graduating now, but you just crushed
yeah.
it. Crushed the rehab. Did a
And
great job.
Case
Yeah.
in point of you are not imaging, your spine
100%.
could look horrible, yet she's a D1 swimmer, right?
Yeah. And graduated PT, 100% goals met, all good.
So I think a big issue with the whole, oh, I'm just getting older. Is it really your age, or is it, if you think of it this way, of when we're younger? I don't know about today. I don't have kids and whatever, but when we were kids, we're outside playing all the time, right? So we are literally exposing our bodies to these different demands and stresses of sprinting, jumping, skipping, rolling, stuff like that. Things that are fundamental movement patterns in order to just essentially just do any sport, right? Or any activity that we would need to do so we're outside playing all day. So when we're younger, we can just jump right into a soccer game or whatever sport and not have to warm up and just be good to go. And it's because kids have prepared their bodies by playing outside all day, that their bodies are primed and ready to go and not experience any mobility issues or restrictions or anything. As we get older, we become adults. We all of a sudden have these responsibilities. We have to pay bills and stuff. So we have to take on at least 40-hour per week jobs where we're not moving anymore. We're not exposing our bodies to those demands that we would get when we would play as kids. Yet we still expect that we can just jump right into a sport and play 3-on-3 basketball and not roll our ankle or throw our back out. And then all of a sudden, oh, it's because I'm old. It's not because I'm not moving at all the other 60 hours of the week.
You're spending 40 to 60 hours a week sitting in a desk chair.
So
the most movement you're getting is getting up to walk to the bathroom and put more food in your body. And, so it's like, you know.
So I think I don't want to call it a lazy explanation, but
in a way, I think it's a cop-out in a certain way. Now,
people are like, oh, it's out of my control. I can't do anything about it.
Exactly. And other than the example about being told by a clinician that you're old, your body's aging or decrepit or whatever, you have arthritis everywhere. I do think I have seen this a little bit with folks where it's like they don't want to go to the gym 4 days a week. They don't want to do rehab or move. Because let's be honest, working out and training, doing rehab, it takes time. It takes effort. Yes, at the end of it, the finish line is you're going to move better, you're going to feel better. This stuff works. But a lot of times people are like, I'm busy. I have to work 50 hours a week. I have kids. I'm trying to pay off student loans. So I have a second job or whatever. And then they just go, oh, well, I'm hurt. My back hurts. My neck hurts. I'm just getting old. And it kind of gives them a little bit of an out to not have to seek help or put in the work or the effort to go down the road of let's address the root problem. So I think people do fall into that trap a little bit where it's like, I'm just getting older. It's just part of life that I'm going to be in pain like this. And it takes the onus off of them to have to do something about it in a certain way. Not everybody.
Don't get us wrong. Age can definitely play a role, right? Technically, we were talking about this earlier today. We have a bunch of, essentially the human body is just a big meat bag filled with fluid. And so when we're younger, we have more water inside of us. And then as we get older, we tend to dry out a little bit. So case in point of if you were to take your skin and you try and raise it up, when we're younger, that skin immediately rebounds and flattens back out. Take a look at someone 90 years old, has wrinkles all over their skin, and you try and pinch their skin, it takes forever for that skin to start flattening out again. And that's a little bit of an example of you're just drier. And when you're drier, it takes longer for positive adaptations to take effect. That's a useful way of looking at it. Should we talk about the stress in the shoulders thing?
Yeah, I think just one more thing on the age component that you started to touch on. I don't want to make it seem like we're saying that age isn't part of the problem, because it can be part of it. But again, usually age isn't the be all end all of
it's not the
this
primary
is the primary reason for my pain. As we age, our skin wrinkles. As we age, our joints get arthritis, right? It's age-related changes. So a lot of times, yes, you can have arthritic pain from aging, and it can definitely cause you to have issues as far as pain goes, function goes. But usually the fix is let's get it moving. Motion is lotion, baby. That's how you fix it. So
motion is the lotion.
You just got to keep it moving. I don't accept, hey, I have arthritis, I'm going to deal with this the rest of my life. It's my aging problem. It just is what it is. No, do something about it. Get moving. Start going for walks.
Get strong.
Start hitting the gym. Get strong. Start lifting weights. All that stuff goes a long way. Even if you just get a rower. Nowadays, we have Pelotons and stuff. Get a freaking Peloton, just ride the thing, do some rows and stuff a couple times a week, and you're going to feel so much better.
What's the best way to combat aging? What's the saying that you used to say all the time?
The fountain of youth is in resistance training. is basically the reality of it. Now, you can do it. There's a fun experiment here because I've had people push back on this with me a little bit. And it's like, if you just go to Google, everyone has Google, go to Google and just type in masters athlete or 80-year-old runner or lifter for that matter. And then just type in average 80-year-old American. Look at the difference in the images of the people's faces, their muscle mass, their body composition, how much fat they carry, just the general appearance of their skin and their bodies, their eyes. You will look at the person who is active and works out and they look like they were 30 years younger than the person who doesn't train, who lives a sedentary lifestyle. It's quite eye-opening if you actually do that exercise. It's interesting to see the differences. And there's other studies and things that come out. They've compared people that are older adults that either run or strength train, and they compare the muscle mass in their quad. And you can literally see that the people who don't train, they have these tiny little quad muscles, and it's just like bone. So it's basically a cross-section view of their leg, and it's like bone and then a little bit of muscle. And the people that train have bone and then a lot of muscle, which people as they age, we tend to get pathological fractures. And you fall, you break your hip, you break your leg.
Gotta get
That
life
could
alert. Yeah.
You gotta get that life alert. The prognostic indicator of hip fracture when you're over the age of 65 or even 70 for that matter, 80, the older you get, those fractures, they can end up leading to the end of your life. So you got to keep that stuff strong. Fountain Youth is in resistance training.
I literally tell
100%.
all my
1000%.
clients that don't resistance train. My old coworker had this saying, and I share it with everyone. I use
Awesome.
it everywhere.
I'm glad I rubbed off on you a little bit on that one. But
all right, last myth is people will say, "Oh, my neck pain is because I carry my stress in my shoulders."
all the time.
I used to be on one end of it where I would be like, whatever, sure, think whatever you want, but I wouldn't really pay any mind to it. Now, the way that I've been treating over the past few years, that I think there is some validity to it. However, I still don't think it's the root cause of what's going on. I think it can contribute to it. And so
It doesn't make anything better. That's
yeah.
for sure.
So there's legitimate research that shows that an increase in chronic stress level. So if you're, I don't know, just like a corporate level office worker or whatever, very high stress kind of job, maybe your home life is super stressful as well. So you're just constantly combating stress 24/7, no breaks at all. Our body's response to stress, whether it's mental or physical, our body's going to respond the same way, is to activate what's called our sympathetic nervous system or our fight or flight mode, right? So now back thousands of years ago, or even 500 years ago, that the sympathetic nervous system was very helpful, honestly essential for our survival, right? Because hunters and gatherers were walking through the woods looking for food and we see a bear, right? So our fight or flight mode has to kick on because we have to decide, am I about to fight this bear or am I about to run for my life, right? In today's day and age, we don't really have nearly as many of those instances occurring. However, we still have the sympathetic nervous system activate due to stress. And so what happens when our fight or flight mode kicks on is our heart rate increases, our blood pressure increases, we start hyperventilating, so we're taking short, shallow breaths like over and over again. And our superficial muscles, so the ones that we train at the gym, they're great for, we look good in a bathing suit, we can move heavy shit, but they're not meant to be turned on all the time. And when we're stressed and our fight or flight mode kicks on, that's exactly what happens, as our superficial muscles just turn on and they won't turn off. A useful analogy is like a Chinese finger trap. If you try and separate your fingers really quickly, the finger trap constricts,
Yep.
right? That's literally what our muscles can do to our body.
Absolutely.
And so when that happens, it's literally we're getting squeezed. And so we have two bones right here. We have our clavicle or collarbone, and then we have our scapula right here. So when the muscles that attach to these bones are on all the time, what will happen is these bones try and get closer together. Eventually, our upper rib cage here is going to get so compressed that it can't compress anymore. But these two bones are going to want to keep getting closer and closer together. So what will happen is they'll go up and over the rib cage, and that's where one potential reason why someone has that rounded shoulder posture, or even when that happens, our scapula, our shoulder blades are going to want to push our neck forward, and that can contribute to both the rounded shoulder and the forward head posture.
That nerd neck too.
Yeah. I don't know about you, but when I'm at home doing notes or something, after an hour, if I'm, I don't know, doing some odds and ends things, or I've waited a little bit longer than I should have to make my payments for house payment loans or whatever, I'm there for 2 hours on why the hell are my shoulders in my ears now?
Literally like this.
And
Yep.
it's that stress response of we're just getting squeezed by our musculature. So I definitely think that there's a component of stress and how that can impact neck pain. But again, I don't think that's a primary cause of it, if
Yeah,
that makes sense.
Absolutely.
Is there anything you would add to
100%.
that?
No, I think that's well said. I agree 100% with it. It's the stress. Stress doesn't help anything. It certainly doesn't help pain. It doesn't help tightness. It doesn't help mobility restrictions, which most people these days have in the neck or the upper thoracic area. One thing that I did just think of while you're talking about the nervous system is in both of our practices, we utilize a lot of manual therapy techniques. Dr. Shadow uses more of the breathing exercise and things like that than I do. But what I find that helps a lot with my clients that do have high stress is hands-on manual therapy. So doing soft tissue work to the neck muscles, the upper trap, rhomboids areas, paraspinals back there, and doing mobilizations and things. And really what that is working on is the nervous system. And the research has come out to really start to prove that it's not so much about the mechanical effect.
We're not breaking up adhesion.
We're really not breaking up adhesions. We're definitely not breaking up scar tissue. And we sure as hell aren't stretching IT band, which you do see still promoted out there sometimes.
That could be a whole video.
Which I'll do a whole video on that another time. That's a myth that we should talk about in a knee pain video.
Yeah.
So anyway, I digress on that. But basically, we're working on modulating that nervous system. And again, in my clients, I work with lifters, runners. Their nervous systems are so taxed because they are lifting really heavy all the time. They're going through grueling training cycles. They're doing cardio. They're doing a lot of really high intensity exercise drills that are just crushing their nervous system. And that increases stress on your body. So if you're a stressful job, stressful home life, and then you're putting your body through stress at the gym, your nervous system is just shot. So that's where, honestly, the manual therapy techniques, the soft tissue work, the joint mobilizations, the manipulations when we're getting a cracking effect in the spine, doing nerve gliding techniques, cupping, dry needling as well is huge on this. It's all modulating. Yes, you're getting some local changes mechanically, but it's mostly working on the nervous system, brain-body connection, and just basically turning that switch off that the brain turns on of, hey, we're going to guard this area, we're going to tense this stuff up, we're going to protect it. By doing the hands-on work, it basically turns that switch off so that we can get you back to your normal resting tension and length. And back to the talking about the chiros from earlier. Then we roll into active movement patterns so that we keep that nervous system down, show you how to move
without upregulating that fight or flight mode.
Exactly. Yeah. Perfect. Yep.
Awesome.
Well said.
You too. All right. So let's talk about how our assessment process would be for a client that would come in for neck pain. So right off the bat, let's actually start with some things that we would want to ask someone to make sure that they're safe to treat and they're in the right place and we don't have to refer them out. So these are called red flag questions. They're just meant for us to be able to identify, is there something that could be more serious that's occurring that you need to get that checked out first before you work with us, or we might just not be the right person for you at this time. And that happens, right? I've referred plenty of people, I know you have as well. So what are some of the red flag kind of symptoms that you would want to screen out?
Number one thing is with any neck is, do they have numbness and tingling in all four extremities, especially if they look up into extension? That's a question I usually ask. And also any passing out, drop attacks, anything where they're just have had any issues where they're going unconscious basically for no reason at all.
They're 1 minute they're gardening, the next minute they're on the ground. And they're like, how did I get here?
Difficulty breathing and swallowing is a big one. Numbness of the face is a big one. And that's screening out more kind of cancers and things like that happen. Head and neck
issues with blood flow to the head as well.
Or vertebral issues. A big one is gait. Some PTs out there skip their gait assessment. Don't skip your gait assessment. You look at someone's gait and they're like all over the place. They're uncoordinated. Something just doesn't seem right with their nervous system. Something isn't connecting well from brain to body. Those folks might need to be seen by someone other than PT, because they can have myelopathy where they're actually got some issues where the spinal cord is getting compressed. That's a big one, is looking at gait. And that one gets missed by a lot of early entry-level PTs. Oh, I don't have enough time to look at gait. I'm just going to do my manual muscle test, look at my range of motion.
Look at their gait. Focus on the area.
Yeah, exactly. Look at the function of the person. And cranial nerves is a big one as well that can tease out some wonky things that can be, because there's a lot of things that can happen like brain and vascularly that can cause neck pain and headaches. And that's when you hear about those crazy situations where people go to a chiropractor or even a PT that does manipulations and they get the vertebral stroke of the neck. And a lot of that's actually going on before they go to the provider, because when you have a vertebral artery issue, it causes neck pain and headaches. And who's the first person you go to see? PT or chiro usually. So it's one of those chicken or the egg things. But I think that pretty much your strength, overall strength, any asymmetric.
If you're all of a sudden just dropping things for no reason.
Like you can't hold a coffee cup, you're dropping.
Especially if it's just getting worse and worse and worse and worse progressively over time. That's a big clue that something more serious could be going on. A big one could be a new onset of headaches. So either you've never had headaches in your life, or it's a different kind of headache. So, I mean, headaches are very common, and it's the neck can be a very common source of headaches. They're called cervicogenic headaches. But if it's a new type of headache, or you've never had one, and now all of a sudden you are getting this, it's abbreviated WHOL, worst headache of your life, especially after the age of 50.
Huge red flag.
That's a big red flag. If someone tells me that,
Like,
I'm not even going to assess it anymore.
Room,
Let's
honestly, urgent care, emergency room, go get checked out. Because people, that's a sign. Worst headache of my life is you're having an aneurysm or something crazy, something not musculoskeletal that we're not going to be able to fix in PT.
However, if it's like maybe it's a new headache, but you've had a headache before, or it's not really that intense, what would confirm whether or not we can help is if, hey, can we either make the pain worse or make the pain better just by moving the neck? If that's the case, then it's more likely that it's a mechanical issue and something that we can actually help with. Yep. If it's nothing changes or everything just makes it worse, then that's a drop in the bucket of maybe we might want to refer you out. One other one was unexplained weight loss or weight gain. Unexplained is the key word there. That might be indicative of something more serious going on. The other one was
reflexes.
Yes.
Inverted supinator sign.
Those types of, what are the primitive reflexes, right?
Yep, exactly.
That or hyper reflexive. So I check your bicep and you're knocking yourself out.
Or it's like clonus, or like that would happen more so at the ankle or even the knee. But reflex testing is huge. Another thing that I feel like it's skipped by the busy PTs in the clinic, seeing a lot of people a day. You'll skip your neuro exam, reflexes, or sensation even. Don't skip that stuff. Definitely spend time on it.
So if you're watching this, one of the 6 people that probably end up watching this, and you have any of those symptoms, please
go be seen by somebody. Get that checked out.
What are some of the common things?
Oh, another one that can also pop up. Shoulder pain here that you'd think is upper trap with history of smoking or shortness of breath. That one is those Pancoast tumors, right? Pancoast tumors or whatever.
Tumor in the upper apex of your lung, right up here.
At the top of the lung there, and that can put pain right in your shoulder. And it can appear like a classic neck-referred pain pattern right to the upper trap there, that mid-cervical referral. Those situations you need to do, that's where you need to just do a good history taking. Any history of smoking, has there been any weight loss or anything like that? Any other of those cancer red flag screens that we do? Any unexplained weight loss or anything like that going on?
One other one, actually. We're spending a lot of time on this, but it's better.
This is important stuff.
Yeah, these are
the ones you can't miss.
So I actually had someone that had that tumor when we were working together. It was a mix of, it was a mechanical thing. So she actually did have an issue with her neck. And so she did have a history of smoking. However, we were able to get positive changes in her symptoms. So I said, doesn't seem like anything serious right now. It wasn't until she mentioned about maybe a month in, she was like, the pain gets so much worse at night, I can't fall asleep. Yeah, so that's called night pain. At that point, I was like, it might be a good idea to go talk to your primary care doc. And lo and behold, she ended up having a tumor. And I'm actually getting chills saying this out loud. She was not given a very good prognosis. Probably not with us to this day, but I kept treating her just to manage symptoms. But
it happens. Like you learn this stuff in school and you think, oh, that'll never happen to me.
And she's been dealing with this neck pain for years.
And that's a thing that's also...
So I beat myself up over it. I was like, could this have gone any other way had I picked this up a few weeks ahead of time? It was so advanced at that point. She needed to address it years ahead of time. But
that's something that's like, you didn't do anything wrong in your assessment or anything. It's just she's been dealing with it for years. She's been seeing doctors along the way. No one picked it up. Our job.
Luckily, I told her to go.
If you didn't tell her to go be seen, it would have gotten to the point where
she wouldn't have even known.
She would have had. It would have been like just stage 4, like everywhere. She would have been having some other symptoms. So it does happen. You hate to see it, but the best thing to do is just screen those red flags, check things out. If people aren't, another thing, not red flags, but lack of progress. So you're unable to change those symptoms at all for better or worse, or if you can't reproduce the symptom, anything like that, people might need to be referred out. It might not be mechanical pain. It could be organ pain. You can have referred pain from your spleen. You have a kidney stone and cause back pain.
Liver pain can cause shoulder pain. Or liver issues can cause shoulder pain.
Exactly.
So again, if you're watching this, you have any of those symptoms, go to the hospital, go to your primary care doc, whatever.
Do something.
But so
checked out.
Assuming all of that stuff is cleared, what does your assessment process look like for someone with neck pain?
I want to know what their routine is like. What do you do for work? What's your training schedule? How do you spend most of your day? What are your habits? I also want to look at, as far as history goes, is this something that's been coming and going? Have you woke up with a quote unquote crick in your neck, or a stiff neck, like that classic, oh, I slept funny, and you could pull your car out of the driveway and you're like, oh shit, I can't even turn my head today. Oh my God, what is this?
Turn your whole body.
Has it come and gone?
What is the behavior of the
changing?
Symptoms?
Has it gotten better, same, or worse?
What's the location of it? Is it only in the neck? Is it in the upper trap, in the rhomboid, in the shoulder blade? Is it going down the arm? Do you have numbness and tingling?
Any nerve stuff?
So if you do have pain that's going down the arm or numbness or tingling, that increases the likelihood that you could have a disc issue, whether it's a disc bulge, disc herniation, or something else that could just be putting pressure on that nerve. So we have nerves that exit the neck, they run through the shoulder, all the way down the arm into the hand. And so if there's an issue here, nerves don't like being compressed, right? So as soon as they're compressed, they're going to send a signal to the brain saying, hey, start experiencing pain or numbness or tingling. The only issue is the brain can't tell exactly where that signal's coming from. It's not sure if it's coming from the neck or anywhere else along the path of that nerve. So essentially the brain just guesses, right? And it's like, oh, I think I feel it in the arm, or oh, I think I feel it in the hand.
Super common.
So that'll be another thing that we want to ask about is where is it located? Does it move up and down? Does it only stay in one spot?
Yeah,
Stuff like that. Anything else you would like ask about during the initial interview?
Probably just like, I don't know, the classic, what treatments have they done before? Because I want to know what they've tried. Has that not worked? I want to know how it's progressed. Has it been getting worse, staying the same, getting better? Time of day is a big thing I ask about because that helps me with my diagnosis for what anatomy is involved. If it hurts first thing in the morning, a lot of times discogenic pain can be worse first thing in the morning because of the way that the disc rehydrates at night when we're laying horizontal, not up against gravity. Does it hurt with coughing, sneezing? Those are also indicators of, hey, is this a disc problem? Is it a facet? What do we got going on here? Those are just my differential diagnosis tests, just subjectively. I think as far as subjective, that pretty much covers it. And from that, I go into a posture assessment. Usually, like I said, I have people sit on my table with no back support. They end up hunched like this after about 10 minutes or so. What's your pain? 0 to 10. It's a 5. It's in my shoulder blade, into the side of my shoulder. Correct their posture. How's that feel now? Oh, I don't feel it in my arm as much. So now we know we have a referred pain pattern coming from the neck. And that's going to give us an indication of how we treat it. From there, look at range of motion, of course, is like number one. What's your range of motion looking like in the neck, the thoracic spine, shoulders? Muscle strength testing is a biggie with any neck issues, especially with referred pain. Because we want to know, hey, do we have a myotomal weakness pattern going on here? We're going to take a look at nerve tension tests, which is part of the cluster for diagnosing if they have a radiculopathy or like referred pain from the neck. So you're going to look at median radial nerve.
These are the main nerves that run down the arm. There could be compression either at the neck or anywhere else along the path of that nerve. And essentially, we test it either with this position for the median nerve. You ever make the mask with your hands? This is for the ulnar nerve, and then the radial nerve is away from you like that. So if you will compare it side to side. So are you unable to get into that position? Does it feel super tight and restricted? Or if you have a full range of motion both sides, is one side more symptomatic than the other? Those are all comparative tests that we can use. Maybe we try an exercise and then we retest it. If it's better, then we know, hey, this is an exercise that is definitely going to be added as part of your homework to help address any of that neural tension.
Absolutely. And that's a big thing, I think, also that a lot of newer, like entry-level physical therapists tend to miss is not looking at the nerves. And you can glean a lot from doing nerve tension tests. And I've had clients come in where I'm like, it's kind of tricky. It looks like a neck. It could be the upper back. It could be shoulder. And then lo and behold, I do a nerve tension test and, oh, that's my pain and that's in my shoulder blade. And I'm like, all right, nerve tension test. We have some neural tension going on. So clearly we do have a spine issue here. So it can actually really help rule in and rule things out. After that, we're taking a look at joint mobility. So I try and get hands-on as soon as possible with my clients. So I'm doing P to A mobilizations where I'm actually assessing each segment of the vertebrae, starting at C2, working my way all the way down to C7, and then we go to the thoracic spine, assess the mobility there. Most often than not, you're able to find which segment is tender or causing their pain. You might even reproduce some radiating symptoms when you're doing that type of assessment, which helps me as far as knowing my anatomy. All right, we got a C4-5 problem, or so we can be more specific with our treatment, with our hands-on approach.
As well as even like mobility drills that
we're prescribing.
Hey, yeah, if we do rotation, that's going to be more like cervical versus like if we work more side bending, that's going to hit more that, C5 area, right?
Absolutely.
Those are all good.
And spring testing to the thoracic spine after that too, to see if we have any referred patterns there, or assess that joint play, because upper thoracic spines are stiff again with our just lifestyles these days. After that, once I have a good assessment of that, do some special testing. Look at our quadrant test. So can you rotate and extend? Does that cause any discomfort if we're closing down? So there's opening and closing of a joint. So I want to see how does it respond to those positions. Sperling's test, give them a little compression. Have them look up, side bend, compress the head. Does that cause pain? If it does, it usually tells us we have a neck problem that's referring to the shoulder, arm, or the upper back. You decompress, so lift up on their head. Does it relieve symptoms? Tells us we got a neck problem. If it relieves symptoms when you lift up on their head, usually that's you got something going on with the neck. And then from there, it's repeated motions exam, which is it's a bad rap out there. Is like McKenzie stuff. I feel like a lot of people feel some type of way about the McKenzie treatment protocol. I used to be one of those PTs where I was like, McKenzie shit, that doesn't work. It does work. It's not for everybody, but it is when you find someone that has a symptom change with the repeated motions, like the McKenzie protocol, they get better and they can get better quick, and it can really you could like change someone's life in like a couple of sessions, which is pretty freaking cool. It's not the be all end all for everybody, don't get me wrong, but definitely we put them through a repeated motions exam because there's a lot of value there. It's not just like, hey, am I going to send you home with these chin tucks to like this disc problem, whatever? Yes, but if you're sitting at a computer all day and I have you do this 10 times where you protract, or if you just look down and flex and we're lighting up your whole arm and you're getting numbness instantly down your arm, there's knowledge for the patient to like, oh my God, like me sitting all day is jacking me up. I need to stop doing that. So there's a ton of value in putting them through those repeated motions. And then what I say to my clients is, we're going to put you through this repeated motions exam. What we're going to find is there motions of your neck that we need to do less of so that we're not irritating things? And is there motions of your neck we need to do more of to make things feel better? Usually, they're game for that. And then they see the connection of how their symptoms feel in real time with you. And they're like, oh my God, I didn't realize that I could literally turn my neck pain on and off by moving a certain way. There's tons of value to that. And you can really identify.
Actually, it gives people control over their bodies and symptoms. Like that alone
really
can be so powerful for someone and improve someone's like mental outlook on their situation. Of like talked about before, of like you have the spine of like an 80-year-old lady and you're 17 years old. But if, first of all, who cares what your spine looks like on imaging? If you can get rid of your symptoms by doing something as simple as this or this, and you're pain-free, like
the amount of numbness out of your arm.
Yeah, like
that's
the
been
amount
freaking
of
you out for 2 months.
The amount of like power that you're given over your own life is freeing to people, right?
For real.
Just that aspect. Now, primarily we'll use it more so for the symptomatic improvements, right? Like people just don't want to be in pain, right? But so it'll address the symptoms. It's probably not going to address the root cause of why it's happening in the first place. Of like, if you're a CrossFit athlete and you're snatching overhead and if you don't have the shoulder mobility to get up here, what you're going to do is try and compensate and probably jut your head forward.
Throw your head forward.
Yeah. Or if like you don't have the hip mobility in order to get down into that squat, into a snatch position, again, you're going to compensate and risk overloading the neck. And that's why that neck issue cropped up in the first place. It's not like the disc just didn't spontaneously bulge or herniate out of nowhere, right? It's not spontaneously combusting. Like, our bodies are master compensators, right? So like our bodies are going to get the job done regardless of whether or not you have that mobility. If you're not going to get it from the shoulder or the hip, it's going to get it from somewhere. And if more often than not, if you're not getting it from the shoulder, it's going to put excessive stress on the neck to get that job done. And maybe it works for a while, but eventually you're going to accumulate enough stress to that area that something's going to go. Again, the repeated motions can be life-changing for getting rid of some of the symptoms, but again, it's not addressing that root cause to make sure that it doesn't come back again.
Also, one point I just want to mention, that was really well said. Other thing too, from like a clinician standpoint, is it gives me a very clear indication of the patient's prognosis. Like you come in and we go through repeated motions and you got this pain in the shoulder blade, it's in the shoulder or here, upper trap, and we have you get you on the repeated motions protocol, let's say chin tucks, for example, and we're able to get that pain out of the arm to centralize to the middle of your spine in visit 1. That tells me that in 2 weeks' time, your prognosis is excellent to get better. And that is it's such an awesome tool to have as a clinician, to be able to actually tell someone who's been dealing with pain for months and like crazy symptoms, they're freaked out. And you're like, look, we just centralized your pain today to the spine. In 2 weeks' time, this is going to get so much better. And I can say that confidently because we have research to back that up. And then you can just see like face light up, like, oh my God, like I'm going to be okay. And even that, we'll do this another episode later, but like pain science realm and things is like people encouragement and having them believe that what they're doing is working because they're seeing it work in real time. They are going to do so much better if they just came in and you're kind of willy-nilly, oh yeah, you got this pain. All right, yeah, we changed a little bit today. Like, it's going to get better.
Yeah. Just cookie cutter exercise program.
Do chin tucks, do
like
the no
monies,
and
next to you.
But yeah, it'll get better, but they're not really seeing the progress or you're not connecting those dots for them. Been really powerful.
Yeah. Being able to change someone's pain,
with my patients.
Like having them do it themselves, right? Like
that is the cool thing about McKenzie. It gets a bad rap, but like really do a good job of making the program like self-driven by the patient.
That's the word I was looking
which
for,
is really, now don't get me wrong, I love manual therapy. I love being able to put my hands on somebody and make a symptom change. Like I just like helping people. That makes me feel good. But when you give someone the power and the autonomy to then take a simple exercise where they can like know that they have this tool in the back of their pocket that they can do any time of the day to like make them feel better, It's hard to describe
It's
how beneficial
powerful.
that is, how valuable that is for somebody, especially people that have been like pain and they've been given no answers. They've gone to, us being in like cash pay kind of out of network realm. I don't know if you've noticed this, but I've become a little bit of like the person people come to after they've seen like chiropractors,
When all
three
else fails,
PTs, they've
yeah.
seen acupuncture, they've done all the things, and they're like, well, I've done all this shit. What's going on? And I'm like, well, let's see. And then I end up being the one to find out, well, it's been your neck the whole time. Sorry to tell you, you did PT for 3 months doing, scapular stabilization exercises, and the whole time it was actually your neck, not your shoulder. Digress, but basically, you can tell the person that you're trying to help in the moment knows that you've got it pinpointed to fixing their problem because you just made the symptom change in one session that they didn't get for 3 months doing stabilization exercises and
Yeah.
arm bike,
Yeah. Yeah. Right.
heat and stim,
If you ever go to a
trigger
PT
point
clinic,
releases.
yeah. If you ever go to a PT clinic and you show up, the PT that you're working with is also working with like 2 or 3 other people at the same time. And essentially you're in this routine of showing up 2 or 3 times a week. You start on the arm bike, then you do some pulleys, then you do like snag rotations or something.
If you're lucky, you'll
Go,
do that.
yeah, right. Go through like an exercise sheet of like 30 exercises that don't change week after week. Get out of there. Hey, unless you're feeling better,
Unless you feel better.
feel better, sure, go ahead. Like that works for you. For the people that you're not getting any improvements, if you've already been there for a few weeks, why keep? If nothing's feeling better, why keep doing it? Right? Like it didn't work for the
Absolutely.
first 2 weeks. Something clearly isn't. The dots weren't connected. The root cause wasn't uncovered. Something is going on that hasn't been discovered yet or isn't being addressed. You need to find someone else. Either have a conversation with your PT of like things aren't changing. Can we like take another look at it? If they're not willing to, leave. Go find someone else that is willing to listen to you, work on uncovering what the actual root causes are. And that I think is, to summarize kind of like everything that we've talked about the assessment process, uncovering that root cause. That
All
is
about the root cause.
primary goal of our evaluation, is to make sure that we uncover the root cause and figure out what exactly is going on, give you some answers behind that, because that's the first problem that people run into when they come and work with us is they don't know what the hell's going on. Mm-hmm. So that's the first problem that we try and address, is giving you clear-cut answers, or at least shedding some light on, here are your restrictions and here's what we think is going on. That alone can be very valuable to someone, of like, at least I have some answers. We have at least some explanations as to why I'm feeling how I'm feeling. The other problem that we address with the evaluation is, okay, know what's going on, but how do we get to where we are at now to where we want to be to achieve our goals? And that's where at the end of the eval, we'll make sure to sit down with everyone and kind of write out with you, develop a plan of care with you on, here's what we need to do to get you back to being able to do handstand push-ups, or even just like reach overhead, or do a pull-up, or whatever it is you want to be able to do that your neck is limiting you from, giving you a step-by-step plan of how we're going to get from point A to point B and achieve those goals.
Absolutely. Yeah. For the folks out there that have been dealing with stuff, you've been seeing a PT, like you could really get along with them. They're a very nice person. Like PTs are like people to hang out with, like them. That's great. Like they're not there to be your friend. They're there to fix your problem. If you have had 6 visits with a physical therapist and you've had no change in your symptoms, like pretty much relatively the same, you need to go be seen by someone else. Nothing against where you're being seen at. There's limitations to the time and things in certain clinics and how they operate with as far as like volume and things like that. They basically, if you're not better in 6 visits and seeing some progress,
and sometimes
the root cause hasn't been found, or it's an other thing that's going on that needs to be deeply evaluated by the medical side. But I would say if you're not seeing progress in 6 visits, definitely seek out another physical therapist. You're doing the insurance-based model and you look around the room, there's 5 other people there while you're being seen. Although your physical therapy might be nice to you and you have a good relationship with them, like just the confines that they're in time-wise, they just don't have the time to be interested enough in your problem to fully test and find what that root problem is. So you need to find someone that has the ability to do that. And that's where a lot of times, that's where I have people that have been seen by other PTs and been to the big box PT places of the world, and they come and see me and they're like, oh my God, you spent the whole hour and a half. I spent 90 minutes in my evaluation, really trying to get at the bottom of the root cause of things. It's that important to us. And lo and behold, spend that time together and we're able to find a solution. And we're really surprised that they did PT for 3 months, charged their insurance like crazy. And I saw them in 1 or 2 sessions and were able to get a symptom change, because I have the time. It's nothing against PTs. I have the time in my practice to basically be interested and test out, You do those in-depth tests to make sure that we know what we're dealing with.
Yeah. But yeah, you
goes a long
mentioned
way.
something good about like the whole 6 visit mark thing. Sometimes, like if it's chronic, right? So chronic technically is greater than 3 months. Like I don't know about you, but I've seen people dealing with things for years, decades,
10
even.
years.
A lot of those cases, and I've even had a handful of like acute cases too, like in the last like few weeks, maybe subacute, like within like 1 to 2 months, where the symptoms take a lot longer to improve. That doesn't mean after 6 visits, if your symptoms don't improve, ideally they should. Sometimes they don't though, but as long as there's other things, either mobility or strength that's improving, that's still progress. So sometimes it just takes longer for the symptoms to subside, but as long as your mobility is getting better and your strength is getting better, the pain should follow suit eventually. It's just, the body's very complex. We know less about our own nervous system than we do about like the universe. So like human body's so complex.
We're learning more.
But yeah. Sometimes the nervous system takes a little bit longer to calm down. But again, as long as you're making other physical improvements, it should follow suit.
Yeah. Glad you threw that in there. So
yeah.
Pain can be a little bit different on that front as far as like symptom change. So 6 visits might be a little like low as far as expecting a chronic pain change as far as like pain goes. But like Dr. Shadow just said here, as long as you feel like your mobility is improving, your strength's improving, you're getting some benefit to what you're doing, you're on the right track. But if you're seeing no progress at all by 6 visits, I would highly recommend seeking out care elsewhere. It's like anything. You go to get a surgery, you get a second opinion. Why not get a second opinion, in PT? I think that we can save a lot of headaches and save people a lot of copays and unnecessary imaging and things like that if they see someone who has the time to get at the root cause of their problem and truly educate them on a path to addressing their limitations and reaching their goals in a matter-of-fact way, not like hey, yeah, you got a shoulder impingement, like, strengthen it up, it's going to get better, and 3 months down the road, you're like, well, yeah, I'm stronger, my shoulder doesn't feel any better, I don't know.
Yeah.
And then you come and see me and I have you do 10 chin tucks and you're like, oh, my shoulder pain's gone. I'm like, well, sorry to tell you, you've been doing PT for the wrong thing for 3 months.
Yeah.
See it all the time. I see it all the time.
Yeah.
I'm sure you do too.
Yeah.
10 chin tucks. I'm like, all right, raise your arm up. It was a 5 before. Now it's no pain. Oh, great.
It's such a quick and easy thing that you could just add into an eval that unfortunately a lot of PTs don't add in. Again, we're not trying to bash other PTs or anything, but it's just a low-hanging fruit that we'd be doing.
It's almost egregious that it gets missed.
Yeah, we'd be doing our clients a disservice if we didn't do that. Again, because it could be a home run for some people. Yeah. And that, anything else that you would add?
Again, just to reiterate what you said. There's a lot of really good PTs out there working at like big box places, the insurance, in-network operations that are out there, but they just don't have the time.
Yeah.
And that's a symptom of our healthcare system. We all know it's not great right now.
I mean, take a look at like going
to a primary
care
doctor.
Like you see him for 5 minutes.
If you're lucky,
you're in the waiting room longer than you are actually seeing the doctor.
Yeah.
Unfortunately, that's just how the medical industry is trending toward more and more towards. That's what we're trying to fight against that a little bit and give our clients the care that they deserve. Right?
And honestly, get the word out to other PTs too. There's a better way to doing this stuff. Like if you're like us and you've worked for, I don't know what to call them, in-network places. I don't want to single out any names, but chain PT places. Like if you find yourself dreading every single day that you go to work because you have 20 people on your schedule that you need to try and help. You're gonna slide evals in there and double book you and things like that. Just find that like patients aren't getting the outcomes that you can get with them if you had just more time to do what you need to do. There's another option, and you can start your own cash pay clinic. You can, people like us that are growing our businesses and doing well and reach out to us for mentorship or come shadow or, we'll be hiring probably in the next, 6 months or a year or so. So like you might be able to, there's a new way and a better way to do physical therapy, especially for athletes and active individuals. I think it's giving them the time to be interested in their issue and fixing it. And that's what we can offer in this model. Just out there, kind of crazy out there in the insurance-based world where people are just seeing way too many people a day.
Yeah.
The patients have a good outcome, for the PTs to have a good outcome. Everybody's burned out, tired, they hate being at their job. It's not a good place to be. So rest assured there's better options out there, and out of network world, I think we got a really good thing going on. And with the movement to like HSAs and things like that over the last couple of years, like everyone's got high deductibles, everyone's paying out of pocket. So, you get what you pay for.
Yeah.
You pay more money, you get better in 6 visits. yeah, you might have spent a little bit more up front, but that's better than you going to see a PT for 6 months that was treating the wrong thing,
Yeah,
or missed the boat entirely, and then all of a sudden you get a surprise bill. You had a $3,000 deductible anyway, and oh my god, I'm paying more than what I would have paid to see Dr. Shadow. And we give people better and less visits.
Yeah,
less time, less visits.
We're just better.
Just better, and yes, and we have more time to work with our people, and like we're just interested. We want people to do well. We want our clients to progress and hit new PRs and achieve their goals. So anyway, that's what we're here for. And thanks for having me today, Dr. Shadow. It's been a lot of fun chatting. We'll do more of these in the future, hopefully.
Yeah. But yeah, thanks for tuning in to episode 4 of Vital Conversations. Again, Dr. Jim Zalewski, if you are dealing with an active condition or active painful condition in the Philly area, his practice is called Path to Performance Physical Therapy, right? Hit him up, and you won't regret it for sure. And stay tuned for the next one. Take good care of you.